Ladies and gentlemen, and the misfits who refuse to stay in their lanes, welcome to the World's Mayor Experience. I'm your host, Joshua T. Berglan. For the new listeners, let me give you the lay of the land. We do not do small talk here. We do real talk. We strip away the corporate veneer and the media spin to get to the marrow of the human experience. I stand here as a man who has battled dissociative identity disorder and who navigates the world on the autism spectrum. But today, you're going to see something else. You might see me shaking. It's not just in my hands, it's in my neck, my head, and my entire body. You might hear the struggle in my speech. These are not just tremors. This is my body reacting to the world in a way that most people can't imagine. I feel every single frequency. Whether it's an electronic signal, human energy, or the raw power of Mother Nature herself, it surges through me in a very supernatural way. It's painful, it's exhausting, and it's an absolute battle just to talk into a microphone. But I refuse to hide it. These are not my weaknesses. These are my credentials. Because when you've been broken by the system and when you feel the weight of the world literally vibrating in your bones, you learn to build something better. We talk a lot on this show about shadow prisons, the cages society puts us in. Sometimes those prisons are mental, like psych wards I survived. But sometimes the prison is your own body. It's the cage of chronic pain that tells you that your life is over. But I don't want to just talk about breaking out. I don't just talk about breaking out, I provide the keys. If you're looking for answers, whether it's about mental health, media sovereignty, or spiritual warfare, I have curated thousands of free resources for you. Best way to find them is to use our custom search engine called the Archives, built right into my platform. Type in your struggle and let the library serve you. And for those of you who are done consuming and ready to start creating, if you want to build a brand that is cancellation-proof and a legacy that outlives you, I invite you to work with me. As the omnimedia architect, I help visionaries weaponize their story to serve the world. You can find all the details at joshuatberglan.com. But today, we are speaking to a man who holds the physical keys to the prison of pain. My guest today is a man of science, but he operates with the soul of an architect. He is a Duke-trained surgeon who realized that the medical industrial complex often treats the human spine like a demolition site. I know from experience. He looked at the way traditional surgery strips muscle and fuses bone, locking people into a permanent state of limitation, and he decided to rewrite the script. He is a pioneer of minimally invasive spine surgery. He is a man who believes that cutting you open should be the absolute last resort, not the first option. He has flown patients in from Nigeria, Norway, and Venezuela to his clinic in Miami because he offers something the system rarely does, the chance to keep moving. He treats the elite, from Miami Dolphin players to the MMA fighters, but he also treats the grandmothers who just want to hold their grandkids without weeping. And perhaps most importantly, he has been on the other side of the needle. He has been the patient in agony, the one staring at the ceiling, wondering if the pain would ever stop. That experience didn't just make him a better doctor, it made him an inventor, leading to the creation of Pillow for Pain to help us heal while we sleep. Please help me welcome the liberator of the spine, the man who turns agony into agency, Dr. Georgiy Brusovanik. Did I say it right? Brusovanik.
Awesome. Thank you so much. I appreciate it. Georgiy Brusovanik. Thank you so much.
Oh man, when I repeated it to you before we started, I got it right. But anyway, I apologize about that.
Perfect. Thank you.
I am so excited to have you here as somebody who's had I've had multiple back surgeries. I've been fighting the medical industrial complex my whole life in different ways. I love people like yourself that decide to go a different route. When they're pushing you to go this way, you decide to go another way, just from a sense of you just care and you recognize that doing it this way that we've been told to do may not be the best way. the fact that you actually care to listen to your patients, and then you had your own experience that helped you realize maybe there's a better way. So I appreciate the stand that you're taking, because I know, having worked with physicians most of my life, especially surgeons, breaking away from what the rest of the group doesn't really make you always the most popular guy. So I have a lot of respect for you, and I'm really, really excited to learn more about you and your invention.
Thank you. Thank you so much, Joshua. I really appreciate it. What have you gone to talk to you?
Excellent. Before we get into your question, sir, I would love to know, what are you grateful for today and why?
I'm grateful for my parents. My parents brought me here from Russia, and I really grew up with a silver spoon in my mouth. I went down a well-paved road: high school, college, med school, residency, fellowship. So I get a lot of like oohs and ahs of 14 years of school, but objectively, I didn't invent anything along that route. I was just listening, and I was very lucky. I got a bunch of scholarships, so I was able to go to school almost for free. I was very lucky, so super grateful for my parents. And you know what? When we left Russia, they used to say how they don't want me to ever serve in the military. That sounded like nonsense. Why would I serve in the military? World War II was, 80 years ago. And now they are conscripting soldiers in Russia for this horrible war with Ukraine. And they were right. They were totally right. I would have 100% been sent as cannon fodder.
Well, I'm glad that you're still here, because you are making a huge difference in a lot of people's lives. So
thank you.
Are you ready to get into your questions?
Let's do it.
All right. Now, I talk a lot about shadow prisons of the mind. You have said that chronic pain, if severe enough, can drive you mad. Do you see your role as a surgeon not just as a mechanic of the body, but as a liberator of the mind?
Yeah, for sure. And it comes to play on two sides. So the first is you don't know what the problem is. You have anxiety about the problem. You're asking things like, am I going to be like this forever? That's a prison. That's an anxiety producing, sleep ruining, relationship ruining prison. And when I see these moms with 3, 4, 5 kids who say they don't remember the last time that they had a day with no pain, you can really see it. You can see how pain ages you. You can see how pain destroys relationships and careers. I had a guy here who flew in on his own G6, sold his company for some billions of dollars. He said he still hasn't even been able to celebrate the moment because he's been just nonstop in pain. Can you imagine? A patient of mine by the name of Luigi Mangione, maybe well known to some people, the guy who killed the United CEO. And when I was asked to talk about him, all I really wanted to discuss is the fact that when you have surgery and you get into that second prison, which is not only are you in pain, now you got surgical pain, and now you're part of the system, yet the system wants nothing to do with you. Hey, I need to find out what's wrong with me. Well, go to therapy. Hey, well, I need some imaging. Go to therapy. Hey, well, I did the therapy. I'm not better. What do I do with my imaging? Well, you got to make an appointment. We'll see you in 3 months. I got to work. I got to live. My girlfriend's not going to talk to me anymore. And that's that second prison where you're already part of the prison. You thought you were out and they brought you right back in. And the exit seems like it's nowhere to be found. So I've been on the first one. I've never been on the second one. And I'll tell you, even when I was in the first one, the prison of not knowing what's wrong and prison of, am I going to be like this forever, before surgery. Already back then, you can't compare me to everyone else because I knew what the problem was. I had no anxiety about the problem. I knew exactly what needed to be done. I was just guiding my care.
Yeah.
What if you're like everyone else? An MRI is a mission. Getting somebody to look at the MRI is a mission. Getting proper injections is a mission. Getting follow-up is a mission. So yeah, it's definitely a prison. And it's a prison without visible walls, which is even more anxiety producing. Josh.
You got that right. Oh, great answer. Now you lived the nightmare. You went from being the surgeon to the patient, suffering severe back pain yourself. How did that experience change the way you look into the eyes of a person sitting across from you? Did it change your definition of empathy?
Yeah, definitely. Not in a good way, though. Not in a good way. So, as a surgeon, you got to be ethical, and you can't rush people into surgery. So you got to pick the problems that don't have to be operated on, which is 99.9% of them, where a patient is a candidate, but they don't have to have surgery. You got to make that very clear. So people would come in and they would see me and I would tell them, don't rush into surgery. Try this, try that, get a second opinion. Take your time, take your time. Because I thought I was being a real nice guy. I thought I was like, kind of save them from unnecessary risk. I think the patient's dying in pain. Okay, I can help you, no problem. But I always try to be very slow with going to the OR. And then 3 years ago, I get my first epidural. 2 years ago, I get 2 epidurals. I'm sort of good between the epidurals, but it's not great. There's a little bit of apprehension. My back hurts. And then last year, come like March, I can't even sleep. I'm sleeping with my legs up in the sky. My daughters are on both sides of me in bed trying to sleep. And I'm laying there wide awake, screaming at night, like silently screaming. So I had 5 epidurals. Nothing worked. And then I called my old friends, my old mentor from Stanford, and it was like a Tuesday. And I was like, I need to have surgery next week on Monday. Period. I'm not waiting. I can't live like this. So I chose a different pathway for myself than I do for everybody else. So first of all, it made me question my ethics. And second of all, now I see patients in my office and they're saying things like, I'm dying in pain, I can't live like this. And I feel more righteous saying, I'll just fix it. I try not to waste their time as much. It's good. Problem is that I'm now more aggressive, which is sort of kind of the opposite of good. So maybe I'm more in tune with my patients, not so much more aggressive, but I'm acutely aware of the fact that when a patient comes in and says, I've done injections, I'm no longer forcing them to repeat the injections. I'm sort of being more, maybe I become a better listener now. Because of dying in pain, I'm saying, okay, let's just fix it. It's okay. So.
Well, so many people say that with chronic pain, so many with chronic pain are just told that it's all in their head, or they're just given antidepressants. You have a strict rule. Don't assume pain is psychological until all physical avenues are explored. Why is the medical system so quick to dismiss what can't immediately be seen?
Josh, this is a hill that I'm ready to die on.
Listen, I'm here for it.
Nobody wants to be in pain.
No.
Number one. Unless you're doing some medical legal work where patients are faking it, nobody wants to be in pain. 1. 2, if you have pain, it's coming from somewhere. So this whole thing about it's all in your head and we got to rule out everything else. I'm trying not to be real ugly in this, but bottom line is, if I can't figure out what's wrong with you, it must be in your head. That's not logic. That's just absence of knowledge.
Right.
So I'll give you a controversial topic right off the bat. Shoulder tightness, headaches, pain under the shoulder blade, pain going down to the arms in a 35-year-old mom with 3 kids who never has time to sit. And she's got this like this close to crying kind of attitude. What's the diagnosis? 9 out of 10 family practitioners are going to say fibromyalgia. There's no diagnostic criteria. There's no imaging. There are no labs to prove the diagnosis. There's no EMG. There's no nerve conduction study. There is just a constellation of symptoms and a label. So now we're not calling them hysterical. We're not saying it's not in your head. We just have a better name for it. Fibromyalgia. No outcomes measures. No chance of getting better. Try one of these 10 medicines that are not even indicated, that are meant for something else, like seizures, depression, etc., and then live with it. Meanwhile, I get MRIs on these poor girls, and I find it's a C5-6 disc problem. I give them an injection, all their pain goes away. And if it goes away temporarily, I bring them back, I replace the disc, and voila, fibromyalgia is gone. So which one is it? Are we mislabeling them? Are we not listening to them? I just think that medicine is a lot simpler than we make it out to be. We create complexity because we're trying to justify our lack of knowledge. When we don't know, oh my God, it must be in your head. Oh, it's fibromyalgia. It's some nonsense that nobody can put their finger on. Chances are it's a red button like everything else. And when you find it and you push on it and it hurts, you have your confirmation. So I'm like a deep, deep, deep believer in these few ideas.
I love it. I love it. Now, you said the price we pay for being bipedal is that we load the lumbar disc. That feels like a design flaw in human evolution. Are we destined for back pain just by standing up, or is modern society breaking us?
Great question. I think that we're destined for back pain because we're bipedal. We're loading our spines, which look very similar to dogs and horses and ape spines, but we're loading them way different. We put a lot more pressure on the bottom disc. Some people's bodies are made for that, where the bottom discs, the bottom bones are a lot thicker, but some are not. And you do see a high, 60% of humans have back pain, severe back pain at some point, but 20 to 30% have neck pain. It's a lot. So there has to be something structural that we are doing that results in back pain. That being said, though, look out the window. There's not a single person out there crawling on all fours. Very rare. So the reality is that, you can blame God, you can blame bipedalism, or you can blame age. But the end point is you don't have to live in pain. And I think if there's one message that I can transmit to your amazing audience, it's that there's no such thing as normal pain. There's no such thing as normal back pain. If you live in pain, then there's something wrong. And it doesn't mean it's something catastrophic. It means that you're like everybody else. Something is wrong and your body is telling you so.
That's so good. Let's talk about the old way versus the new way. Traditional surgery strips the muscle off the bone. You use a keyhole approach. Can you explain to the layperson who's saving the muscle, or who is saying the muscle is the difference between recovering and suffering?
That's a big difference, huge difference, especially because not only is the morbidity lower when you don't cut stuff, you can also do things that you wouldn't be able to do otherwise. Because look, your spine's in the middle of the body. There's organs all around, and then there's muscles and nerves in the back. It's hard to get to your spine without making a really, really big hole. Sometimes it's impossible to expose a large segment. For example, you go behind the kidney or you're behind the diaphragm. Big, wide open exposure still doesn't mean that you're going to have good access. Now, put a tube. I can operate on somebody who is obese. It's a tube, so I'll use a longer tube. In the end, I can bypass all the fat, I can bypass all the soft tissues, and still arrive at where I need to go. But there's even more. And I can't really take that step with you until I give you a 2-sentence preamble, which is one, where does pain actually come from? So I'm really big into that. You come to me in pain, I have back pain. You need a diagnosis. It's not enough to say back pain. It's not enough to even say it's L4-5. Which is the problem? Is it the disc or is it the joint? I'm not trying to overcomplicate it. But the second part of the preamble is we got to listen to the old experienced guys that run the educational bodies, like in every profession. In my world, it's called AAOS, American Academy of Orthopedic Surgeons. And these guys, using great biomechanical data, great studies, have concluded clearly that if you want to cure someone of back pain, you have to restore their sagittal balance. It sounds real scientific, but really it's very simple. You got to make it so that the person's head goes back to being on top of their butt. Think about it. As we get older, we start to lean forwards. We get into what's called kyphosis. You got to go back to where your head is above your butt, but you can't get there because the front of your spine, the discs have gotten short. So the American Academy said that restoration of sagittal balance is most associated with back pain relief, meaning that as a surgeon, I have to give you back your height. I have to make you taller. And I'm not talking about leg lengthening stuff. I'm talking about sneaking in, removing the remnant of the disc and replacing it with a much taller device, either a fusion device if there's deformity, or a disc replacement if there's just disc degeneration. This way you keep your motion and you get your height back, you place your head back on top of the butt, restore the balance, voila, the back pain is gone. So back to your question, how is minimally invasive better? It's not just better, you can't get there with classic surgery. Classic surgery, straight down, you can't restore the height. If you distract and pull across the bones and put screws and rods, the bones just won't knit together. In order to get the bones to knit together, you got to compress them. So from the beginning, in the best of hands, you go from the back, you're going to have a 36% failure rate. You go from the side or the front, which is done through a tube, and the rate of failure goes down to less than 3%, less than 1% if you do a disc replacement. So it's not even a factor of recovery anymore. You just can't accomplish restoration of height by doing the classic fillet of the back muscles, screws and rods.
You just described how my back surgery experience is.
I'm sorry, Josh.
But my second one, thank goodness, I started racing mountain bikes and being young and youthful again. I'm very fortunate. But the first surgery, it was awful. Literally the next year had to do it all over again.
Oh.
And that, as you already know, and anyone who's had back surgery, the rehabilitation process is awful. But I'm very fortunate because I started working out within 7 days, wearing my back brace. I did all the things that I needed to do to rehabilitate. I'm very fortunate, but I was terrified because I have a very addictive personality and already had an addiction problem. The thought of taking Oxycontin and some of those other pills, it was terrifying to me. So I wanted to I'd been around working in healthcare for 18 years. I'd been around people that were taking hundreds of painkillers a day. I didn't want that life. Again, it was bad enough just fighting my other addictions that were way more fun than, but also way, dangerous, and they're all dangerous. The drug addiction was dangerous, period. But I didn't need to add something else to it. So I was very, very fortunate. And I had wished that I had actually done more research ahead of it. But I actually, this is not a planned question, but as we're talking about this, I'm thinking about it. I just went to the doctor that my attorney told me to go to because I was in a car accident. Someone ran a red light, hit me. I'd already had spondy. It just made the situation worse where I required surgery, but I went to the surgeon my attorney recommended. Can you advise? I don't know if you're even allowed to advise on something like this. Can you talk about that when attorneys are the ones that are telling you which doctor to go to? Can you advise on that?
Yeah, for sure. Listen, I specialize in saying the right thing and pissing people off.
I'm here for it.
How it is. Look, most of these guys have it's like a gang. Every patient's channeled the same way. The higher the cost of care, the higher the reimbursement from the case. So it's pretty obvious that the goals aren't aligned here. And there's probably a reason why they're goading you to go to the specific doctor. It's pretty transparent. It's sad when patients fall in cahoots with this and say things like, "Oh, just do this little surgery for me, and then I'm going to make more money." That's pretty ultimate desperation. So I'm not trying to badmouth anyone who's in that world, but there shouldn't be anybody pushing you to go see a spine surgeon or to have spine surgery. You should not be pushed to have spine surgery, period. Okay, so that's one. But I think there's a deeper question here. Josh, you're asking me really, how do you pick a doctor? How do you know
yeah, there you go.
To is full of it. And I'll give you a couple of ideas. Look at the reviews, specifically the bad ones, and see what they responded to the bad reviews. Because if he's flippant about it, if he's if he doesn't respond, if he clearly doesn't care about somebody that was left behind by rude phone service or his own rushing, that gives you a clue. Second, you show up at the office. See what the relationship is between the doctor and his staff. Because if he's a dick to his staff, I wouldn't trust him with your care, right? First time you meet that guy or gal, he's going to be, or she, at his best behavior. So if that first appointment, he's looking at his watch, he's about to rush out of there, he's not answering questions, he's not offering you to ask questions, what's going to happen if you have a complication? Is that guy going to be there for you? Is he going to pick up the phone in the middle of the night when you get searing pain down the leg and you're not sure if it's normal? So that's the next thing. And then I like for you to ask the doctor to talk to his patients who had a complication. You want a doctor who is really brave, who's going to be there for you, then he knows all his complications. All of those patients likely like him now because he was there for them. He didn't leave them on the battlefield. He took them out as he was supposed to. That's the guy you want. Because complications happen in the best of hands. You just want to make sure that if you go to battle with somebody, they're not going to abandon you.
Can I elect you for the head of the American Medical Association by any chance?
Listen, Josh, I'm honored, but clearly I'm unelectable.
You're my kind of human, sir. Oh my gosh.
I'm honored.
I'm an architect of media, and you are an architect of the spine. Traditional doctors love to fuse bones together, locking them in place. You specialize in motion preservation and total disc replacement.
Yeah.
Why is maintaining movement so critical for a human being's sense of sovereignty?
You know, it's like a whip. You know, you take a long green piece of a branch, and if you keep whipping it, it's going to break wherever you're holding it. Same thing. You see concentration of forces above the fusion. Human spine is meant to move. It provides, it forces better blood supply. It allows flexibility. You got to be able to get up from a chair in a smooth way. We have great biomechanical studies that show that once you fuse a segment, the motion of other segments is affected negatively. You see this ratcheting kind of movement, especially in the neck. And we know in the neck, the chance of having to go back for surgery, if you have a fusion, is close to 100% if you have more than 30, 40 years left to live. So there's no question motion preservation is the way to go. Why would you want to lose motion? And there's other, really far-reaching effects of fusing versus replacing the discs. And myself personally, as a recipient of a disc replacement, man, it's a miracle. I mean, I'm a normal person again. I was a normal person within like a couple of weeks of surgery. Like I could pick up my kids. I have a bunch of stone crab traps in the bay here. I go with my kids, and they're like 60, 70-pound traps. You know, they're heavy. I have like 18 of them. Don't tell the local Marine Authority. I went about a couple months after I had my surgery. I thought the season started. I thought, man, is today going to be the day I'm going to ruin it? And nothing. I traveled to Republic of Georgia, horseback road, climb mountains. Nothing. Whereas you have patients who have fusions, they talk about 6 months of recovery. 6 months. When you talk about your recovery, Josh, my head comes off to you, man. I'm sorry. That's brutal hard. I mean, I took 2 Percocets and I really didn't even need the second one. And that's what I hear from my patients. Look, it's a good time to be a spine surgeon because we don't have to, use a bow and arrow anymore. We can do the right thing, we can help patients. It's really rewarding.
It's amazing. You treat high-performance machines, MMA fighters like Valerie. I don't know if I'm allowed to say names. Anyway, some high-profile MMA fighters.
Sure.
When a fighter trusts you with their spine, they're trusting you with their career. How is the pressure of operating on a champion different from operating on a civilian?
It's not as high as operating on a mom who's got a couple of kids. Yeah, that athlete's going to be fine. I mean, these surgeries have a high success rate, but when I get like a single mom with like 3 or 4 kids, now the pressure is high, now I really start to worry. I operated on this old veteran once, and he had a dog, a golden retriever, and he spent like a week in the hospital, and I was so worried about that golden retriever. So I treat everybody the same. And listen, athletes don't have more pathology than mere mortals like myself. So, you operate on them when they really need it. And I treat everybody the same. I'm much more worried about a single mom than a high-profile athlete.
I believe that with all my heart. I've been just from all of your other answers, I believe what you just said to be absolutely true. I love that. I honor that so much.
Thank you, John.
In my archives, I help people find truth. You use diagnostic injections to find the truth of the pain before you cut. Why is an MRI not enough? Why do you need to prove the pain source before you touch the patient?
Oh yeah, real simple. So we know from good studies that were done on people with no back pain, and these people had MRIs done, that 80% of them have some surgical pathology, painless. So that means that we all get disc degeneration, but we don't suffer from all of them.
Mm-hmm.
We don't suffer from all of the discs that are bad. So we know that chances are it's 1, max 2 discs that are causing your pain, especially with degenerative conditions. Now, if you have nerve pain, you can sort of trace the nerve back to the level and confirm which is a bad level. But what if it's somebody who is over 40 or 50, where it's multi-level? How do you really know? And listen, I'm a revision guy. I do mostly patients who've already had spine surgery that failed. And I'll tell you something, about once a month, I'll see a patient who had surgery on the worst disc, and their pain is coming from the second worst. Once every 6 months, I'll see a patient who had surgery on the first disc or the second disc, and it's the third disc, the third likely culprit that's causing their pain. So how do you resolve that? Nerve conduction study gives you a ton of false negative, unless you have constant numbness. MRI just shows you which discs are bad, doesn't tell you which ones actually hurt.
Mm-hmm.
So I thought, well, why don't we just keep it simple? Do an epidural right then and there with a little bit of local. If that's your culprit, you should have your pain disappear at least 70-80% of the way immediately after the injection. There's nothing like it. A friend of mine, ethical spine surgeon Case Poelstra, he recommended putting the medicine inside the disc, but there's some toxicity with that. So you are hurting the disc a little bit, and also it doesn't address the area where the disc is touching the nerve, because you're putting the medicine inside the disc. You want to put the medicine right behind the disc, and there's a way to do this called the transforaminal epidural. It's a very safe epidural. It doesn't hit the canal. If you go too far, it just goes and hits bone, so it's safer.
Yeah.
And in good hands, like my partners, that's all they do is transforaminal epidurals. You go from both sides, inject the level. Are you better? I mean, we talk right away with the patient. Are you better? If they say they're 70-80% better, I can guarantee you that I can fix them. So if that injection wears out, quote unquote, or doesn't work later on, and they try again and they say, Doc, I can't live like this. Okay, I can almost guarantee you that your pain will be gone, because I'll tell them, remember how you were after that injection? Okay, well, you can be like that or better. And it's clear, it's obvious to everybody. It's a foolproof way to know exactly where the pain's coming from. And a few times that I cut that corner, I regretted.
Wow. That is really profound. So interesting. Okay. You didn't just stay in the operating room. You became an inventor. Tell us the origin story of the pillow for pain. Was this born out of frustration with what was available? Or is this a personal necessity?
I love the story. So my old boss at Duke, Bill Richardson, this old school guy, just a giant of spine. Whenever patients would come in with elbow pain and neck pain and tingling down the arm, in order to figure out if the nerve problem was coming from the elbow or from the spine, he would tell them, take a big fat towel, wrap it around your elbow, put tape over it, and then sleep like that. Now, what is that going to do? The towel will stay on your arm. You can still bend it. But when you get to like maybe 90 degrees, the towel will bunch up in the antitubural fossa, and then you can't bend it any further. So we know that at night, most of us sleep in a fetal position. Wrist flexion from the fetal position causes carpal tunnel syndrome, and elbow hyperflexion causes elbow pain and irritation of the ulnar nerve, which then goes down to your fingers and causes numbness and elbow pain. But you can have more than one thing. You can have elbow pain and a neck problem resulting in the same kind of tingling. So if you sleep with this towel on and your pain goes away, voila, it was the elbow all along. You sleep with a towel on, and after a few days, you still have the same tingling, then the problem's coming from your neck and it's not from your elbow. The problem is that me with my poor English, to explain to somebody to use a bath towel, to tape over it, I start to sound like an idiot. So I started thinking about it, and I thought, I was looking actually at bracelets from ancient Egypt, and they look just like the stuff we're selling now. I'm talking about same leather, same straps, like incredible. We've had no innovations in bracing technology. And what's a brace? It's a way to use a function of a material to supplant a missing function for your body. So I was like, is it really only straps and stirrups? So then, thank you so much. So then I came up with this pillow. I was like, well, why don't we wrap your elbow in a pillow? I tried a few different designs. We did away with tape, and then I got Velcro involved. So I created this thin little pillow. Look, I'll show it to you right now. Pillow. It's really simple. I made it of like really cushy material. We added some Velcro. And then once you have it on, it's a lot more appealing than wrapping your arm in a towel with tape. And now look, I can bend it, like I can scratch my face, but I'm having to use some force. If I was to fall asleep and my muscles want to relax, the pillow will get me out of that hyperflexion. It's super comfy. What was most impressive about this invention, I really didn't expect this, was how quickly it works. Because I was telling patients back then, try it for about a month. Then I started to get calls from friends of mine, and they were like, we thought it was a placebo. The first night I put it on, my pain was gone. And listen, it makes sense logically, because if you give your arm a night of rest without that hyperflexion, the elbow relaxes and the pain stops. The tingling really only happens because the nerve is so tight in the antecubital fossa, right behind the quote-unquote funny bone. So pillow for pain came alive, and I guess I'm in business now.
I'm going to ask you this later too, but where can people buy the pillow?
You can just go on pillow4pain.com and number 4, pillow4pain.com. You can go on Amazon, Shopify. It's sort of everywhere now. It's gotten sort of surprising popularity now, I guess because of its efficacy. It's really working.
Have you gone on QVC or the Home Shopping Network with it yet?
Not yet. I don't know if I'm brave enough. I just, it's like wearing colorful clothes. I don't think I'm cool enough.
I think your personality would be a smash hit on QVC. I love it. All right, I'm going to get back to your questions, but I was just curious because, I'm already going, I got to try this. This looks amazing.
Yeah, of course. I'll definitely send you one. I'd love to hear your opinion.
Oh, I'll give you my opinion. I will give you an honest opinion too.
So I ask.
Now, most people don't realize they are injuring themselves while they sleep.
Yeah.
You talk about the fetal position compressing the ulnar nerve. How are we unknowingly sabotaging our bodies for 8 hours a night?
Look, I think we as people give ourselves way too much credit. Most of life is spent floating on daily work. You think you make a lot of choices, you really don't. And you can't really, control how you sleep. You can try, you can put a pillow between your legs, but you move around, you toss and turn. You can't control that.
Sure.
So I think the best thing I can answer is stop blaming yourself. It's not your fault. These things kind of happen. You get older, things get more crabby, joints get stiffer, you get a little bony overgrowth, capsular changes. So it'd be nice for folks to stop blaming themselves and really just address pain as it comes. Most of these things, they're pretty minor, and they can be addressed with simple, small things, not necessarily surgery. The worst is when you are starting to watch your life be destroyed because you can't sleep at night, because the elbow hurts so much. So I don't think we really have an option here. We're going to sleep the way we sleep, no matter how hard you try. There's no way you can control how you sleep. So unfortunately, it's going to have to be something simple like that, a little device here and there. Those who grind their teeth, put in a little, Invisalign or whatever protector. Those of us who have an elbow problem, or how about carpal tunnel syndrome, you have to wear a brace that sort of gets your wrist into this position at night. But now we have something for the elbow. I want to do something cool. I have 2 little girls, and above all else, I'm a dad. Above all else, I'm a dad. I love being a dad. So my kids, they're really into businesses. My daughter is already doing vibe coding, making apps using AI. My 7-year-old has just had her art shown on Art Basel, and she's creating all this new art. So I'm real proud daddy. So they watched this thing be born. They watched me create prototypes, draw it up, make it, ship it, get a partner, get a storefront. So I'm really excited about getting this thing to work because I want my kids to see that within a year, 2 years, you can create a business and you have all the tools at your disposal. I'm using it as a teaching point.
I'm at that. Of all the amazing things that you've said so far, that to me may be my favorite. I absolutely love everything you just said there. Wow. Now, it seems counterintuitive for a surgeon to create a product that helps people avoid surgery, but you believe rest is a powerful healer. Is the pillow for pain your attempt to put yourself out of business?
Well, the thing is this, I do spine surgery, back and neck surgery. So it's really my attempt to put my partners out of business. but to be completely honest with you, the surgery for this problem, which is on the nerve trunk position, where essentially you get behind the funny bone, strip the nerve, and then move it on the other side of that bone. It's not a good operation. Nerve can get easily hurt. When you strip the nerve, you lose some blood supply, and then you put the nerve in an unnatural place, sort of above the muscle, so it's easy to irritate it. So truthfully, there is really no good option for this problem, which affects as many as like 50,000 Americans every month. Mm-hmm. And I only know this number is because apparently between 50 and 200,000 Americans buy new elbow braces every month. And most of the problem is, as I mentioned, from sleeping with your elbow in hyperflexion. So there's definitely a place for surgery. And I think that, sometimes I hear another argument, because I'm sort of a big opponent of stem cells and similar nonsense that doesn't have a lot of science behind it. And I get comments like, oh no, he's a typical surgeon, he's supposed to operate. My question is to those folks, if stem cells were so good, why are we operating? Why aren't people getting better? You got to assume that most doctors are in it for the right reasons. I assume that if you're a doctor, chances are you're trying to help people. You may be misguided, and I'm sure there's some terrible apples out there. No one's trying to scam, or very few people are trying to scam, and do some surgery that you don't need. Although I do see that quite a bit, I don't think that that's the majority at all. So look, we're just doctors. We're just trying to find better solutions for our patients. And pillow for pain was sort of my little stint at helping patients who otherwise don't get better with surgery.
Have you, a random question, but have you ever considered attempting to get medical coding for it where insurance companies would pay for it?
Oh, yeah. We're like about a month shy of that. So we applied for Medicare. Yeah, for sure. So it will be available for patients at no charge for Medicare, and insurance will cover it. There's nothing like it on the market. So there's really no reason for this not to get approved. We're pretty close to getting approved. So it's a great comment, Jeff. I appreciate that.
The fact that you know this is amazing to me. I that was one of the roles that I had in healthcare, was if the insurance company would deny something, we would find a way to get the code to be able to get it approved, because for a long time we couldn't get Medicaid and Medicare to pay attention. I specialized with complex disabilities like ALS and muscular dystrophy, but we did a lot around seating and positioning and wound care or wound prevention. And yet, as you know, they're not real big on paying for preventative items. So we always found a way around the rules to get the coding done so we could get it paid for on behalf of the patient. Because if they're not able, the easiest way to prove it is, if this doesn't help you if this helps you complete your daily living activities, there's a good chance you can win the appeal or you can get it coded. So we kind of took that route. But that's usually how we fought back against the insurance companies. We're able to get things funded. So the fact that you're doing that is brilliant, and it's going to help you help more people. And I think that is phenomenal.
I'm super happy to hear you say this. Yeah, no, definitely into it. I was doing this live, and a nurse from somewhere in Kansas chimed in that they'd love to use this for patients in the ICU. Some of those patients who are intubated, sedated, they move around. Every time they move around, the elbow gets exposed. They get pressure ulcers on the elbow because it's touching the bed or plastic. So you're right. It's probably a good idea to try this for patients, maybe even in surgery, because we've had patients in surgery pretty well. Yeah, you definitely opened my eyes. That's a great point, Josh.
Yeah, I'm excited you're doing this. Okay, so now I think this is really, really neat that you've done this as well. Now you've used eco-comfort materials, recycled resources. I'm all about this. Why was it important to you to build a medical device that was also environmentally conscious? Is that part of the healing?
I mean, look, it's 2026. We're trying to be civilized. We're trying to be a little smarter. So it's such a small thing to change.
Yes.
Get a better property of material. Nice to know you have something on your skin that's not toxic. And plus, my partner, her name is Sharon Lior, is a very talented person with great taste. And she insisted that we do something with like luxurious materials that are gonna feel nice against the skin. I'm really glad that I listened to her. Plus, again, I had to impress my kids by making the right decisions.
I love it. I love it. Now, we are in an opioid crisis. People like myself are terrified of back surgery because they fear the addiction that follows. How does your minimally invasive approach change the dependency on painkillers? Can we heal without the narcotics?
So you definitely need less pain medicine if the surgery causes less trauma. So after my disc replacement, I took 2 Percocets, and I really didn't need the second one. It takes a lot of work to become an addict. For a normal functional adult to go from there to being constantly numb and itchy and sleepy and then needing more medicine, it's counterintuitive. So first of all, we got to stop all these blame games. People are not taking narcotics for the most part because it's so much fun. They just to make it through the day. Grandma is not buying heroin under the bridge to kill the excitement of life. It's because her pain management doctor is not filling her prescription. So that's an important thing to acknowledge. The other part is, and I don't think we talk about this enough, because we talk about doctors writing pain management prescriptions or not writing pain management prescriptions. I think it goes deeper than that. Doctors are supposed to make a diagnosis, not try this and try that. Get a diagnosis. Somebody comes in with chronic pain, giving that patient narcotics is criminal. Because if you don't know what the problem is, you just set them up for withdrawal tolerance and dependence, without a doubt, guaranteed. And I'll tell you some real sad stories from my own life, my own professors, doctors, who ended up with suicide. So the same pathway, narcotics pathway. So no one's gonna outsmart the narcotics. Oh, I can quit anytime. Sure. The reality is very different and very scary. So I think doctors need to really focus on the real medical pathways, which is a patient comes to you with pain, you got to get a diagnosis. We skip all those steps. You need that differential, that list of possibilities of why you are in pain. That's very important to get through. You've got to get a diagnosis. Once you know why the patient's suffering, you have a real good chance of helping them. And it's almost never, just take more narcotics. Now, I give my patients narcotics a lot. I give it to them at will for after surgery. It's inhumane to operate on patients without giving them pain meds. On top of that, it's true, minimally invasive surgery patients take a lot less pain medicine. But on top of that, I do a lot of minimally invasive revisions. So now you're seeing patients who already had spine surgery and they're taking narcotics now for years. So what do you do with them? You can't discard, these are people. You can't just say, I'm not gonna operate on you. So what I do is I'll go up about 150% on their narcotics. So even somebody who's taking 4, 5, 6 oxycodones a day, you have to go up because they're normalized now. Their level of pain daily is just like you and I, just like people who don't take narcotics. So it's inhumane to operate on them without giving them more. We talk about it, we prepare for it, we make sure we're both in cahoots on getting off. And I set a realistic timeline for them, give yourself a month, 2 months until you can really get off all pills. And that's for somebody who's been taking them for years. Take away the pain with surgery and then go through a process where first you decrease the strength of the pills and then you start to decrease the how often you take them. Last thing you take away is maybe the nighttime dose and then you're off. It's a team effort. And again, I'm not big into blaming the patient. I think that we all try our best, but for the most part, chronic narcotic usage for a chronic problem is definitely misguided.
That's so beautifully stated. Now, you are using robotics and computer-assisted surgery. Look 10 years into the future. Will we finally cure back pain, or will technology just manage it better?
So look, I can cure back pain and neck pain today. We're already there. Because motion preservation is there, disc replacement is there, minimally invasive is there, robotic is there. But truly robotic, the way that it is now, it's really more like aiming arms. It's not that complicated. Within the next probably 3 to 5 years, we'll be able to operate behind corners without direct visualization. We'll be able to operate in areas that aren't accessible, like operating behind a spinal cord without mobilizing the spinal cord, operating behind the aorta without moving the aorta. We are maybe like 3-5 years away from that. Autonomous robotics, we're not there yet. Listen, medicine's like 50 years behind everybody else. So before, we're gonna wait a while. You're gonna see self-driving cars way before, and commonly you will see that way before we start to see autonomous surgery. But that being said, that hesitation to adopt new technology may not necessarily be a bad thing. A minor fender bender, you can live with that. But a minor complication is a big complication, no matter how minor it is. So I think it's good for medical pioneers to be a bit conservative with new technology. There's this thing that came out recently. So imagine I get a CAT scan on you before surgery. I feed that CAT scan to the robot, and then the robot helps me to place screws without having to open up the spine. In other words, you make a little focal incision, then you look at the screen where the CAT scan is, and as you are using tools, you can see those tools on the screen, and you can see the patient on the screen. And one day somebody said, well, why don't we put a helmet on the doctor, like a 3D helmet? So now I have this helmet on, I'm looking at the patient, the skin is intact, but I see through the skin. I see their skeleton. That already exists. Sounds cool, right? Problem is that you gotta have Bluetooth working, Wi-Fi working. You gotta make sure that there's no storm in the vicinity, the power is there. And now you're making young surgeons reliant on something that has a big fiddle factor. So in surgery especially, we gotta make sure to stick to some basic principles that lets you save the day when times are rough. So there's definitely a good reason to have strong brakes on rapidity of development.
That's a beautiful common sense a common sense approach and thought process. Because I'm all for, the way that I see AI integrating into healthcare, the benefits for underserved communities are great. But some of the advances, we should be very, very cautious. I don't know how much control we're going to have over some of these progressions and some of the giant leaps of faith in this technology that are going to be taken. I don't know how that's going to play out, but I definitely see the positives, but I see the potential negatives. So I believe that your approach is the most sane approach I've heard in a long time. So I appreciate that. We need more people like yourself speaking up to bring, at least to have proper discussions and have proper debate instead of having something forced on us or done to us without us even knowing. And that happens a lot too. So I really appreciate your approach. And I want to go back to, I hope that someday you get to run the American Medical Association. All right. So I want you to paint a picture for us. A patient comes to you broken in the shadow prison of their pain. 6 weeks after you work your magic, whether it's the pillow or the procedure, what are they doing? What does freedom look like for them?
Well, a week after I did my disc replacement, I went back to surgery and I did this guy Michael, and I had to have a 2 level, but he had a 1 level. So a week after I did his, now I'm 2 weeks after mine, 1 week after his. He calls me on FaceTime from the gym. And he's working out and he has me on FaceTime, and I'm looking at him and I'm wondering, why the hell am I not in the gym? I'm 2 weeks out, he's 1 week out. That's how it should be. Minimal injury, the pain that you had is gone, and you're back to normal. That's how it should be. And we're getting better and better in every field. But it's especially exciting with spine because we figured it out. It's clear now, it's obvious. If you come to me in pain, I'll tell you exactly why each of your elements of pain is there. I'll tell you how you can fix it. If I do a good job, you should be able to go to the gym right away. You should be able to get back to your normal life. I mean, most of my patients don't need therapy after surgery because I don't really traumatize them. So it's like an electrical thing. I feel like an electrician sometimes. I sneak in, correct the problem, and sneak out.
I have to tell you, I've worked with physicians my entire life, and some of my best friends are surgeons. I got to tell you, you have your personality and your just whole way of being is so refreshing to me. Oh, like if all people that should have a giant inflated ego, I would go, you can have one, and I would be okay with it. I mean, I accept my other friends' big egos, but you're so down to earth and just a real human being that like I said, you could have a God complex, and I don't see it. I really, really appreciate your authentic nature. You have amazing wit and humor. You belong on TV. I know that your patients would miss you, but you really do belong on TV too.
Thank you. I appreciate you. You're so kind. Thank you, Joshua.
I've really enjoyed this. I really have. Anyway, listen, I would love to give you the final word. Please plug and promote anything you want to promote, but also if there's something that is on your heart to share that maybe you didn't get to share through the answers in the question and answer section, please share it. The floor is yours.
All right, I got two things. First, we touched this, which is stem cells. Okay, so stem cells are a bunch of babies. And Josh, if I take a 2-year-old or even a 1-year-old baby and I sit them next to you for a couple of months, I promise you they're not going to become a great podcaster like yourself. Babies need to be raised and stem cells need to be guided. And the multi-billion-dollar stem cell industry is based on a fairy tale. Okay, whether you take those stem cells out of the freezer, out of the umbilical cord, out of your fat, or out of the bone marrow where they actually are, the viability, meaning how many of the cells are actually alive by the time you put them into the knee or the hip joint, is very low. And whatever you put in there, your body is going to destroy. Floating around in a sea of joint fluid does not make your stem cells become cartilage. It's wishful thinking. The thing is this, in my world, the world of musculoskeletal pains, most things get better on their own. So a placebo treatment in my world has a 75% efficacy, not 50-50. So if you do something ridiculous for 72 sessions, there's a 75% chance you're going to get better. And then you're going to come back and say, it was those $30,000 stem cells I had in Mexico. That's why I'm better. There's a huge retrospective fallacy, retrospective bias that we're all subject to. So if you're thinking stem cells and someone's pushing you to do stem cells, I'm begging you, get a second opinion. The second thing I really want to start is this thing with testosterone. So in med school, I remember very clearly learning about not messing with your pituitary, thyroid, adrenal axis. All your hormones are interconnected. They start in the brain makes other brain chemicals show up. Those make stuff in the thyroid or parathyroid grow. That makes stuff in the adrenal gland grow. That makes the stuff in the testicles grow. It's all connected. If you start replacing one, you affect all of them. And in a way, which is very scientifically sort of known, which is this negative feedback loop. If I give you more testosterone, you're going to make less testosterone. And when you talk to these docs that prescribe testosterone and you ask them, what's my endpoint? I understand you think I have low testosterone. What's my endpoint? Am I going to always have to do this? Am I doomed for the rest of my life to take hormone replacement? Well, if that's your answer, then that's not going to work, because we know very well from especially bodybuilders who take testosterone regularly that you get an incredibly high hemoglobin, requiring you to take blood out, like you have to draw blood out every month or so. You get blood clot formation. You get other unusual things that happen when you have too much testosterone. And if your body gets used to this testosterone and downgrades its own, now you can never stop, because testosterone for a man is your lifeblood. That's what keeps you going. That's what gets you up in the morning to go do stuff and fight your battles. Okay, but that's not all. How many of you have had your testosterone checked and have been told that your testosterone is perfect? I will bet that it's less than 1%. So are we just bad as a species? Are we broken? Or are we not really testing what we think we're testing? Check this out. Blood glucose, cortisol, insulin, glucagon. These things change like this. You see a hot girl walking by, I promise you, your testosterone will go up immediately. Now, think about the blood draw time. You're hungry, because you probably are going to do your cholesterol right then and there, and you go to a lab, and you're in a rush, and you haven't had your coffee. It's not a sexy time. And that's when we find out that we have low testosterone. Now, I've approached companies to devise a device, to make a device like the blood glucose that you can stick onto your skin that's going to give you a more reliable number, something that's going to be over a whole day. And then you can average it out and say, okay, overall, I'm above, I'm below. But I don't think we are getting the measurements that we think we're getting. And I think that we're creating a situation where these patients are going to be in trouble long term. If you want testosterone, consider biohacking. Consider doing things that are going to get your natural testosterone to increase, as opposed to just adding the exogenous type.
Well, now I have to ask one question, one last one. If somebody is on TRT and they just heard this and they're going, oh crap, I've been taking it for years, what do I do? Can you offer a recommendation?
I can, but I'm gonna get a lot of trouble for this.
I'll be your bodyguard.
All right, fine. In that case, I think that if you need testosterone in your wife, you should talk to your wife.
That's okay. Okay, now
with normal sexual relations, regular sexual relations, you should have no problem with testosterone. People who have regular sex continue to have regular sex until way, way into their old age. Their bone quality stays good, their skin quality stays good, they are more reasonable, their brain functions better. There's a lot more far-reaching effect of having a good, healthy sex life with your spouse, way further far-reaching than we think.
Unbelievable. Now literally you have to have the last word, because I'm going to break my word, but I would like for you to promote your websites and other things where people can find.
I mean, I'm here for you if you have back or neck pain, if you have spine surgery, I'm happy to help. Our website is spinedoctormiami.com. I have an office in Miami, and now we're in New York, Park Avenue, 1111 Park Ave. So I'm happy to help anyone. Insurance, no insurance, patients fly in from all over the world, and I love what I do, so I'm happy to help.
Break free from the shadow prison of chronic pain. Embrace the light of liberation.